So great. Welcome to March's Global Emergency Care Ground Round on behalf of Dharura. Myself and Charlene will be hosting. Well, I think Bitok might be on the call as well. If you're around, please let us know, Bitok. I'm Chris. I'm an emergency medicine registrar. I'm based in Bristol. I've been involved with Dharura for the last year or so, and I'll let Charlene and others introduce themselves shortly. I suppose really for those who haven't been involved in this online platform before, and know a great deal about Dharura. So Dharura supports ethical and sustainable and equal global emergency care health partnerships. So as an organization, we strive to allow health systems and their teams to gain mutual development through sharing knowledge, skills, and innovation. We're really fortunate today that we've got some really great speakers delivering on some really interesting topics from Kenya and the UK. Our speakers try to look into emergency care, whether that be case reviews, research, audit, QI, or a theme. And our theme today, which we'll go on to look at, is around obstetrics, which I think is extremely pertinent and has great value both here in the UK and in Kenya and across the globe. So I think we're going to share a lot of learning here today on this call. And so feel free to ask questions in the chat, unmute, and feel free to ask them on the call. And we've got plenty of time for questions at the end of this session. I'll hand you over to Charlene. She's going to go through some house rules, and then hopefully with an introduction for this first speaker, we'll get started.
Yeah, so hello everyone, I'm Charlene. Sorry, I was slightly late because I was stuck at work. I think there's still a few people that have their mics on. If we could make sure that during the presentations we keep the mics off, that would be great, just so we keep the interruptions to a minimum, and then we can have some questions later on. If you could turn on your cameras as well for a bit of engagement, that would be much appreciated. We will give the speakers a heads up after about 20 minutes to then come to an end so we can go into the questions. And if we could start by posting our names in the chat and our role for us to collect them. And as Chris has already said, these sessions are recorded. So yes, I think we can now start with Karen, who's going to speak on postpartum hemorrhage and the use of the NASG in Kenya.
Karen, you should be able to share your slides.
Yes.
Have a go at doing that now. If any issues, please let me know and I'll.
Okay. Please let me know once you see the page. Are you able to see it?
I think it's getting started. Yeah.
Okay.
And if you just want to try and turn it into PowerPoint and see if you can click through the first couple of slides, just to make sure it's perfect. Yeah.
Yeah, you can see that.
Lovely. Thank you very much.
Okay, thank you so much. I'm very happy to be here today for this very important conversation about bleeding, because I know we will talk about postpartum hemorrhage and also antepartum hemorrhage, which is very important as it's still very significant in causing any one of them can cause maternal death. And that's where most of our emergencies come through. It's surprising that we still talk about hemorrhage as still number one. Hello? Can you hear me? Thank you. Yes, we're still having hemorrhage as one of the main causes of death in maternal issues when it comes to obstetrics, being followed very closely by preeclampsia, eclampsia, which is slowly getting closer to number one, but still hemorrhage is number one in maternal death, and particularly postpartum hemorrhage. You know, antepartum, you can do something about it. Postpartum hemorrhage, you cannot really predict it, and that's why we need to discuss it, and especially in low resource setting areas. And that's why I thought it was important for me to repeat or talk about hemorrhage. My name is Dr. Karen Muthembwa, an obstetrician gynecologist at the Nanyuki Teaching and Referral Hospital. Yes, and I'm here to present about the interventions that we have, simple things that we can do to manage our postpartum hemorrhage, especially in rural Kenya. So a quick introduction on postpartum hemorrhage. Postpartum means anything about after delivery of the baby and the placenta. So that is when we usually have a bit and expecting some level of hemorrhage, but how much is enough or how much is too much? And that's usually the definition, and that is why we needed to define what blood loss after birth is. So postpartum hemorrhage is when you lose or a mother loses more than 500 mils after vaginal birth or more than 1,000 mils after cesarean section. That's according to the ARCOG guidelines. It's still the leading cause of maternal death, in particularly in Kenya. So it's not just in Kenya, but all over the world. We're still having hemorrhage as the leading cause of maternal mortality. It still causes a big burden in rural areas where there's limited access of emergency care. And we see it leads to a lot of transfusions and things like postpartum hysterectomy after cesarean section, just to save the patient. So what are the causes of postpartum hemorrhage? We have the 40 framework, which we've been using globally and all over the place, where we have the 40s, the torn, tissue, trauma, and thrombin. I think these are the things that we keep singing: torn, tissue, trauma, thrombin. You better remember it, because it's not just atony, that is uterine atony, that's the cause. It is the main reason, and that's why we really dwell on atony. But there are other things such as retained tissues, which can be placenta, it can be clots, which can cause a lot of bleeding. It can be trauma, like genital tract injuries, and also thrombin. If a patient has coagulation disorders, like disseminated intravascular coagulation or pre-existing clotting disorders, they can actually present with this. You'll find a lot of women who have postpartum hemorrhage. Some of them don't have an explainable reason. And if you really go back into their history, you'll realize that there could be also a family history of the similar illness. And also, von Willebrand's disease has also shown to be one of the causes of clotting disorders, or the patients usually present with hemorrhage because of undiagnosed clotting disorders and coagulation disorders. This is just a picture. Sorry, I don't know that. Are you able to see it? Yeah, it's just a picture of, let me see whether that, sorry. It's the top, yeah, okay, so you can see the picture of, it's like being in a boxing ring, and you can see that uterus up there, the one I'm pointing at. She's tired, she's floppy, she's big and floppy, as you can see. That one, we're talking about atony. She's tired. There's no way she's going to fight this death over here. So if you see, she's not able to lift the hands, she's not able to lift herself, she's tired, she's fatigued. That's exactly how atony presents itself. When you do treatments down there, you can see when she gets all the treatments she needs immediately. You can see the octopus there, helping her with IV fluids, blood, with injection and all that. You're able to manage uterine atony. She gets masculine, she looks strong, and she's ready to fight. So that is the main purpose of managing and being able to notice a tired uterus early enough. Okay, so what are the challenges? What are the challenges? We have limited health facilities because of long distance to well-equipped hospitals. And then we also have the shortage of skilled birth attendants. You find that most people are afraid of when they see bleeding, somehow there's a lot of panicking. Yet, if you're able to know, if you're skilled, the panicking does not really help. If you're able to identify the bleeding immediately, then that can actually save the patient. You may not need to go into blood transfusions and also hysterectomies. There's delayed recognition and referral, especially in rural places. And I think it's not just Kenya, even in other places like in rural Australia, everywhere. where there is delayed recognition. It's very difficult to manage postpartum hemorrhage when you've already bled out, you're at anemia, and getting those oxytoxic or uterotonic drugs through a patient who's anemic becomes very difficult, and therefore early recognition is very, very important in early referral. Late stage management, again, because when you lose a lot of blood, then the blood which carries even the things, the oxygen that the patient needs, the uterus will not contract. So the earlier, the better. Usually we have issues with blood supply, which we also see even in Nanyuki Hospital and all over, even in Kenyatta National Hospital, which is the main referral hospital. The demand for blood is higher than the amount that is being given out. So we still have issues with inadequate blood supply, particularly rare blood group types like blood group O negative, all types of rhesus negative blood like A negative, AB negative are very difficult to find. So there's still an issue with inadequate blood supply. And that is why we go back to recognition. Poor infrastructure and emergency transport, we've also had issues with that. Not all parts are very accessible. The roads may not be good. Like if you have been to Laikipia County, you can see places like Doldol. If you have to go all the way to Doldol, the road is not very conducive, and it takes 2 hours to come to Nanyuki when it should take less than that significantly if the road was better made. And even the networks connecting from one place to another becomes an issue. Cultural and socioeconomic barriers also. Like, for example, you find people who want to give birth at home. Particular communities don't go to the hospital immediately. They have people who help them to deliver. These are traditional birth attendants who may be available in the rural facilities. And of course, financial constraints prevents them from going to the hospital. So we kept on asking, what are the solutions to all this? What is the solution to managing postpartum hemorrhage? And some of them that came up when different entities come together to discuss. We talk about people who, the traditional birth attendants, are they really trained? Is it worth maybe training them, because we have people who are dying because of postpartum hemorrhage at home because they delivered at home? Is it something that we can look into? Should we train them to recognize postpartum hemorrhage? Because by the time they come to the hospital, we are already at the level where we are anemic, the uterus is tired, we are not able to even give medication enough for that uterus to come back. We end up having a hysterectomy, or worse still, the patient dies. So one of the discussions was, should we train the traditional birth attendants? And so that had been happening. We also have the CHVs, the volunteers. Are they able to identify danger signs of postpartum hemorrhage? Why I'm keeping up to or keeping the discussion onto recognition is because once we wait for that uterus to completely get tired, completely, without recognizing the signs of postpartum hemorrhage, the patient, it's very difficult to go back to square one, where we're just dealing with mild symptoms like maybe pulse rate has changed. By the time our blood pressure is low, we've lost liters and liters of blood. So are we able to recognize? So that's why we talk about volunteers, the ones who go to the community. Are we able to identify those ones with anemia? Those ones who have had postpartum hemorrhage before, those ones who have had a cesarean section. We need to identify such people so that we can be able to know or take care of them better to prevent or even early recognition of postpartum hemorrhage. Antenatal screening is very important. How do we screen for these ones? Are we able to screen for those ones who are high risk? High risk mothers are those ones who are anemic, the ones we mentioned before. They're anemic. They may have an issue I'll give you a picture of who's at risk, just so that it's easier. In the rural Kenya, we have this young girl who's 16 years of age. She's in a community where she only lives with her grandmother, but because her grandmother is not able to take care of her, so they're not feeding very well. And so she decides to sell her, not sell her, but to marry her off to an older man who's maybe able to take care of 3 other wives, and this will be the 4th wife. So this 16-year-old First of all, her nutrition is not very good. She lives with her grandmother. The grandmother is not able to give her anything. So you can see that is the situation of what we have. They are living 12, let me even give a closer kilometer, 12 kilometers away from the nearest facility, which is a dispensary. So this 16-year-old gets married. She's pregnant already. She's anemic. She doesn't, her folic levels are low. We are having twin pregnancy. We are also having preeclampsia. You can see all these risks are all together. The grandmother, the husband don't know anything about going to the hospital. Furthermore, she already had female genital mutilation. And this is a real situation, actually. So she's having a situation where she's now in labor. The baby is not coming because she had history of female genital mutilation, and she's giving birth at home. They are still very far from the closest hospital, which is a dispensary, not even a comprehensive level facility. And she tries to deliver. The baby gets stuck, so we remain there. So by the time the traditional birth attendant says it is not okay, the baby is not coming, you need to go to the hospital, this patient is already having blood in urine. They are in the dispensary and they are 4 hours away from a comprehensive center. So you can see this girl has all the risks for getting postpartum hemorrhage. And this is where we need to recognize how is their nutritional level, how is the economic level, what are their beliefs, okay? Have they gone for antenatal clinic? How do we get to them? And that's how we've gone back to training the traditional birth attendants, the community health volunteers. And also during antenatal screening, we are able to ask them questions. How is your feeding? Because nutrition can actually lead to postpartum hemorrhage. So we have to look back completely. What is our situation on the ground? Birth preparedness plans. You see now this young girl is a teenager. She has no plans of giving birth. She's at home. She's being helped by the traditional birth attendant who is not trained. And of course, the other solution was to encourage them to go to institutions where they can be able to deliver. And especially being young like that one, we do not encourage young girls to get pregnant. But in the case that we find her at that point, how are we giving her access to proper maternity care? So that's how now the emotive bundle came in, because if you're not able, then again, so we start from the community level and try to identify postpartum people who are at risk of postpartum hemorrhage by training the birth attendants, the community health volunteers, talking about nutrition and all that. But in the case that you get a patient who's already in the hospital, how are you able to recognize the problem? How are you able to recognize postpartum hemorrhage? Are you able to measure the amount of blood and say this is more than 500 mils, this is more than 1,000 mils? For a long time, it has been very difficult to be able to measure that. And so postpartum hemorrhage bundles were identified, and the one that I will be talking to you shortly is emotive bundle. But just a quick history on the bundles. We can see that WHO in 2018, together with Bill and Melinda Gates Foundation, then asked 2 questions. Number 1 was, would a PPH bundle comprised of evidence-based technologies be used to strategies, improve guidelines adherence, and improve outcomes? Okay, then the second question was, what interventions would be included in a postpartum hemorrhage bundle? So there are several postpartum hemorrhage bundles, but the one that we'll concentrate on will be the emotive bundle. So these institutions had that consultation on postpartum hemorrhage intervention bundles that are able to handle all kinds of situations, whether you're in rural, whether you're in a modern facility. So we have the IHI, which is Institute of Health Improvement, came up with definitions of care bundles, and care bundles are a small set of evidence-based interventions that for a defined particular patient population, where implemented together shows results that show significant results when you use those small things. So bundling care. So you have several things that when you put together actually helps you come up with a solution for a particular patient who has had postpartum hemorrhage. And some of the things that we bundled together are primary response. How do you recognize when do you start IV fluids, massage uterus, how do you do uterotonic medications, and also the importance of tranexamic acid, right? So the PPH bundle implementation project was done, and emotive was there was a collaboration that became the emotive project, which is now what I wanted to talk about here. And this was to address challenges that when it comes to implementation and the adherence of evidence-based postpartum hemorrhage guidelines by using a bundle approach. So the first thing that needed to be done, because of the first challenge, was being able to identify the problem. So as you can see, there's a picture there I've put. So when you have a patient and she has just delivered, okay, once you deliver the baby, immediately after that delivery of the baby, you need to place something called a V-drip. A V-drip is just a paper, or it could be Macintosh or something that contains a measuring. Okay, so now I'm pointing at this. You can see that there's a V here, and this V has been calibrated in a way when the patient is sitting on this part, the blood that comes out drips into this bag, which is called the V-drip, this one, and it calculates how much blood loss there is. So this is immediately you deliver the baby. Now you drop the V and then able to collect the blood so that you're able to identify the problem. So it has two lines. There's a yellow line and a red line. So the yellow line down there is to show when it has reached 350 cc's of blood. Again, 350 is not postpartum hemorrhage after a normal vaginal delivery. It is just a sign that tells you we are almost getting to 500 cc's, so be in readiness. Because many times we never had this kind of a system. This is a very simple system that can be made anywhere. We didn't have this in a way that we could tell this. We were just guessing. We would carry the things, or you look at the blood and say, oh my God, I think this is 500 cc. No, now we are trying to get an objective way of identifying postpartum hemorrhage. So when it gets to the yellow level, so you don't even need to read, you just need to see the color. Yellow is warning. It's called a warning line. When you get to red, it's action line. Action means action. You need to do something. So that was the first challenge. When do we detect when there is postpartum hemorrhage? And that's how the V-drip was introduced. We have it in Nanyuki Teaching and Referral Hospital. And so the challenge two. Now, what was the second challenge? Was when you see and you're able to see there's a problem, how immediate do you do your action? So when you get to that red line, how immediate do you, what is your timelines of having a response? Okay, and this is where emotive bundle comes in. So let me just show you in a better screen. So the E there is early detection. Emotive is E-M-O-T-I-V-E. E-M-O-T-I-V-E. E is early detection of postpartum hemorrhage. Once you detect at 500 cc using the V-drip, you need to start massaging the uterus as you call for help. There's a drill for this one. So once you massage the uterus for 1 minute, you now immediately, as you call for, you'll do a whole minute. A whole minute. It's actually been documented on, and also it's evidence-based that 1 minute ideally on its own will cause the uterus to contract as soon as is, of course, if there was early recognition. So 1 minute massage. As you're doing that, you can call for help. When your 1 minute is over, immediately go to your oxytocin drug. If you get help, you continue the massage as you become the team leader and tell people, the person who has come, fix a line, fix an IV line. If you can see on the right side, I have kind of like what looks like a pie chart. Fix an IV line, put two of them, two wide bow needles, the biggest or the largest that you have, and then immediately start your oxytocin drugs. The ones available are oxytocin, we have carbetocin. For prevention of postpartum hemorrhage, both oxytocin and or carbetocin can be used, but you cannot use carbetocin as management of postpartum hemorrhage. It's good for prevention of postpartum hemorrhage, but oxytocin is used for prevention and also management. So it's good to note that the two drugs are still important. The only difference is that we have the heat-stable carbetocin. Places where there is no fridge, you can use carbetocin. If you do have a fridge, you can still maintain your oxytocin and how you use it. There are many others, but the main ones in our area is oxytocin and carbetocin. We have agometrine, but also you have to be careful with patients with preeclampsia and other issues, especially heart disease. That's the O. So we talked about E, M, and O. Then we have T, tranexamic acid. So as one person is putting the oxytocin or the carbetocin, then you need to do tranexamic acid, 1 gram IV. And actually in 30 minutes, if you're still bleeding, you can give another dose of tranexamic acid. On one of the lines, you also put IV fluids. You give 1 liter in the first 20 minutes, another one in the next 30 minutes, as you also check your urine output. Okay. Then once you're doing the E motif, you do another examination. Check for those tissues. We said that 4 T's. Check for your tissues. Check for clots. Remove those clots, as you've already done the massage, the oxytocin, and also tranexamic acid, and IV fluids are on. Check what is the problem. Are we having any bleeding? Are we still having hemorrhage? Are we still having atony? So if in case you're still having that, then immediately you need to escalate and go for treatment for refractory PPH. Remember, you can repeat the tranexamic acid. As long as it's used less than 3 hours, it should be able to work. Okay. So I've put the uterine tamponade because it's one of the simple ways of also preventing. So for example, you have atony in that presentation. The simple way that we do the uterine tamponade, maybe some of you have been able to see it, is using the condom catheter. We don't have the Roche balloon in all facilities. Neither do we have the Elavi free flow UBT, but they are there in other hospitals. But it's good to just know that this is still as good. There may be a few differences, but this balloon or condom catheter is very, very useful. You can actually do this as you're referring your patient if you're in a rural facility. So all you need is a syringe. You need that's a Foley's catheter, and then that is you can see that is the condom. And then you need a string, as you can see down there. So what you do is just place, as you can see, it's very simple. You put the condom into the Foley's catheter into the condom, tie it with a string. Then you're going to inflate that small balloon. The one, like when you put a urinary catheter, you need to also inflate that. And then you're going to put fluid through the part where ideally urine would be coming out, and inflate it as you're referring the patient. So this is a very simple way we use to manage atony particularly. Remember, you've checked for the tears, you checked for other things, but atony, since it's over 70%, the reason for most of our PH, we do that. Then we also have the NAS-G. The NAS-G is one of those, sorry, I know that picture is not very clear. I couldn't change the color, but it's being used in several places, and you can see in the America, particularly in America, and parts of Africa and parts of Asia. So you can see it's actually a very good system, which is simple. It's a neoprene Velcro first aid device that looks like the bottom of it's basically like what the army used to use, although what they used to use was the pneumatic. So we're using the non-pneumatic, we're not using air. So this one is just a Velcro that you close, and it's closed in several ways to treat shock and also resuscitate the patient and stabilize and prevent bleeding in obstetric hemorrhage. That's a picture of us. We were with Charlene there, and we were training on how to do the NAS-G. So you can see here, we have the NAS-G, which has different levels, number 1, 2, 3, 4, up to the waist level, up to number 5 there, you can see, and how this is how it is placed. So you can see we've started there with number 1, number 2, number 3, and then there's a big ball here. It's actually at number 5 where you place it over the navel, just to compress the blood vessels in the abdomen. That prevents the bleeding that occurs in the uterus. I think it's important to note that in between where there is the pelvic area, it opens up where you can still, even after putting this NAS-G, you can be able to examine the patient, still put a UBT if you want to, that's a uterine balloon tamponade, you can still refer the patient in this NASG as you are working out the other things if you're also fixing a tear. So NASG has been rolled out in different parts of the country, showing great improvement. As you can see, there's a link there where Migori County was using it, and it has been saving lives. And even now in Nanyuki and Laikipia County, we shall be distributing some of them that were donated gracefully to us. Thank you so much. So basically, as I finish off, there are many other ways that we manage postpartum hemorrhage. Remember, this is not the end. We want to have early recognition using emotive bundle. As you do that, you can use a UBT and also put on the NASG as you refer for others help in a comprehensive facility. So where we go ahead and do now surgical things, like we can do the uterine artery ligation, we can go to the iliacs, we can still remove the uterus, and also doing a billinge, that really helps. And sometimes even cervical tears need to be fixed in the theater, and even grade 3 and 4 vaginal tears or perineal tear. Government and policy recommendations that still are in the work is scaling up the presence of this medication so that you can be able to do the emotive well, strengthening training of nurses and midwives in rural areas, improve emergency transport and referral system, because as much as we do this, we still need to refer them in a safe way, promoting the task shifting to trained community health volunteers, not workers, sorry about that, it's a typo, and also helping them to stabilize postpartum hemorrhage, and then investing in low-cost, high-impact solutions like the uterine balloon tamponade as discussed. In conclusion, postpartum hemorrhage remains a leading cause of maternal death, especially in rural Kenya. If we're able to recognize, the main thing is to recognize who's at risk, recognize when it is postpartum hemorrhage, and immediate action so that you can save the patient. We still need to collaborate together, government, healthcare workers, and also community health volunteers and workers to reduce maternal mortality secondary to postpartum hemorrhage. Thank you very much. I take it back to Charlene.
Yeah, thank you so much, Karen. That was really great. We can open up for some questions. You can either unmute or write them in the chat. Maybe I can start off with one question. In the dispensaries, do they have a way to collect the blood, like with the warning line and the action line? Do they measure it, or is it something that they only have in the hospital?
Yeah, so this is a pretty new make recently. So not all hospitals have it, but as you can see, it is a simple, you can actually make it. The only difference is that they may need to get the V part because it's specially calibrated. Oh, sorry, let me put it back on slide share. Yeah, are you able to see that?
Yes, yeah, that's back.
Yes. So the V part of the V drip is the only part that is special. This one, you cannot just guess it. It's the only part that they may need to acquire. And this is what we are working to see whether the government is able to supply the V part. But the one they sit on, this one, you can actually make it or use a Macintosh so that they sit on the Macintosh as the blood is pouring into the V. So not everybody has this at the moment, but what we used to do a long time before this V drip is that people used to estimate, so they're not able to calculate on their own. So we're still having, still don't have enough of the V drips, but at the moment, for example, in Nanyuki teaching and also in Nyahururu, they should be having, because we do have this, the V drip. We just need to take it to other places, particularly the V part, the V, where it has the calibration. Yeah, so they're still estimating, but the early recognition is still important. So we may need to work on giving them the V drip part.
Yeah. Julie, for example, saying in the chat, we use soaked pads to approximate blood loss.
Yeah, and it's one of the reasons why even when we do the soaked pad, it's still an estimation. It's not an exact count. As you can see, the V drip is able to collect the amount of blood immediately after head is out and the baby is out, when the placenta is still coming out. So we calculate including the placenta separation. It is able to pick out how much it is. So this is what we encourage right now, to use the V-drip. The others, I think people used to try and weigh. So the amount of maybe cloth or packs that have the blood, we estimate, oh, this could be 500 mils, this might not be. Sometimes we look at the patient and see she's still oozing blood, but by the time she's still oozing blood, she may not even have the signs. She may not even have her pulse rate change, because pregnant women are very interesting. By the time a pulse rate is changing, they've lost a significant amount of blood. And that's what people need to know. By the time a pulse rate, and even pulse rate is still missed, people notice the blood pressure, or we notice when she's become unconscious. But by the time she's at that point, it is 2 liters down the line. And that is why recognition is very, very important. So if you're working where you can request to get these V-drips, even better.
Great. Right. We have another couple more questions. So Rita is asking, can we use misoprostol in postpartum hemorrhage, and what's the dosage and frequency?
Very good question. Misoprostol, yes, is actually given for postpartum hemorrhage. It's one of the uterotonic medication. So oxytocin is one of them. Carbetocin for prevention. Remember, heat stable, because it's the non-heat stable. Heat stable carbetocin for prevention of postpartum hemorrhage. Like, for example, the girl I told you, if you have a patient, a young girl, or someone in prolonged labor, you may need to use carbetocin on them to prevent postpartum hemorrhage. But remember, oxytocin still is the gold standard for management of postpartum hemorrhage. At the same time, you use misoprostol. It's good to have mentioned it. Actually, I did not mention it, but misoprostol is given 800 micrograms. You can give it either per rectal if the patient allows you to, or if they seem to be stable and they're talking, can actually give them sublingually and tell them not to swallow. But per rectal, you need to ask for permission, because again, sometimes we forget to ask for permission for particular things. So just don't go and shove up a misoprostol there when she's, she's asked for permission for that. But the dosage is 800 micrograms, either per rectal, or you can still give it sublingually. Yeah. And how many times? You give it once. Yeah. For prevention of postpartum hemorrhage, you also give it once, and you give 600 micrograms. Prevention is 600 micrograms. For postpartum management is 800 micrograms, can go up to 1,000.
Okay, I think we'll come to the last question. Jackson is asking, can we pack with TXA?
The evidence of packing with TXA is not very clear. Usually people try to, but the question is, at what point or what are you packing for, right? Unless you're talking about a tear, or you're talking about a fixed cervical tear that is still oozing, it may or may not, there's no pure evidence that shows that tracheostomic directly onto the area that's bleeding may or may not work. Okay, but I've seen people using it. The results, unless we are able to get them as an actual study, I may not be able to give, but I've seen people getting better even with that. But the main thing is that if you do have a tear that's bleeding, or you have oozing from inside the cervix, you will still need to do these interventions. If it's oozing from the cervix, make sure that uterus is contracted. If it's not contracted, you're dealing with atony, it will not help to do packing with tranexamic. You need to do IV tranexamic acid, and you still need to give the uterotonics. And if it doesn't work, all these interventions, by the way, is every 15 minutes. If there is no action, if they're still bleeding, move to the next step. If they're still bleeding, move to the next step. Don't waste this patient's time. In an hour, you should know that this patient is in theater and you're doing a surgical intervention. If they are oozing from a tear, make sure that you still suture it. Make sure you don't watch it, pouring. You need to suture that area that is still bleeding, because some of them don't stop.
Great. Right. Thank you so much, Karen. I think we all learned a lot. There's a couple of people that asked for the slides.
Yes.
Maybe you can have a look and email the slides to them. Otherwise, the presentation is recorded, and we can also find it on YouTube. I think just time-wise, we're going to have to move on to the next presentation. But if there are any further questions, maybe you're happy to answer them in the chat.
Yes.
Yeah. Okay, great. Thank you so much, Karen. We're going to move on to antepartum hemorrhage now. So a next obstetric emergency by Dr. Anna, who's working in Wales as an ST1. Right. Let me know if you can share.
Yeah,
or if you need any help.
I'm going to share my screen. Okay. Okay. Maybe I should have done this earlier. It says share. Oh, I have to give like.
Is it working okay, Anna? If not, you can send it to me and I can
Yeah,
share.
I think I actually did send it to
I have the presentation.
I've got my Mentimeter thing on as well. I was just hoping to do both at the same time. Give me literally 2 seconds, and if I can't work it out, I'm very happy to share yours.
No, do you know what then? If you whilst you're doing that, is there any more questions in the chat that were waiting to be answered, Charlene, that we could have from the last session, or is there anything else that anyone wants to ask?
So there are just a few comments, but I couldn't see any new questions per se. But it was about calculating the blood loss. So Lydia, for example, had said that they'd been using measuring jars, but the V-drip makes it quite easy for early recognition and warn birth attendants of impending PPH, which, yeah, is a great comment. And that, yeah, they've previously used bottles of fluid, for example, normal saline 500 to measure the blood loss. And then lots of people saying it was a great presentation and asking for the slides.
Thank you. I'll share the slides. Is there a way I can share here? No?
Potentially, maybe on the chat, that might be possible.
Okay, I'll still try. I think there's a place for a file. Yeah, but I think that issue of measuring the blood, for a long time, it's been very difficult, even for a cesarean section. I think we've mentioned about vaginal delivery and how to measure the blood. But during cesarean section, we actually lose quite a bit of blood, more than a liter. If you lose more than a liter, you're in postpartum hemorrhage. There are some drips as well when you're doing surgery that where you can be able to they have bags on the side of the bed. So instead of because anyway, the bags are on the side of the patient, but those are particular drips. Where if you're doing a cesarean section, after you've cut and there's blood all over, the blood pours onto the side. So you're able to measure at the end or just before you close and see how much blood loss you've had. But in our areas, that's why I didn't talk about it, we don't have those particular drips. We're still using how many packs did we use? Still, are we still oozing? How is the pulse rate? Those are the things that have been very difficult to measure. But at least for vaginal delivery, there's this new way of doing it as we work on the cesarean section. Yeah.
Okay. Right.
Can you guys see my screen?
Yes, we can. Just wanted to let you know that we can see your screen and we can see the slides move.
Lovely. So, hello everyone. Thank you so much for your talk, Karen. That was absolutely amazing. Would love to come work with you someday. And absolutely amazing. Yeah. So
you're welcome.
I'm going to talk a little bit about kind of what happens just before the postpartum hemorrhage, probably. So the antepartum hemorrhage. So it's a bit of similar lines, but just a little bit different. So I'm Anna. I'm an obs and gynae first year specialty obs and gynae trainee. So I may not have as many answers to the questions as our previous speakers, very knowledgeable, but I'll obviously try my best. I've never been to one of these before, so I was just wondering if I've got a Mentimeter up. I was wondering if people could put in, if this works, I'm going to try and make it work, what their role is basically, like what level they are and from what specialty they are, and then I can kind of try and gauge who I'm talking to.
I think as well, Anna, if people aren't able to use the
maybe they're not able to do that at the same time.
they might be able to just put in the chat, which I think they're doing. So
oh yeah, cool. That's fine. I was just trying to also just get people on the Mentimeter. That's all good. Awesome. Oh, that been drawn on? Okay. So we're going to talk about Mia, who's a lady who, not her name wasn't Mia, but a very similar patient just attended to us a couple of weeks ago. And just kind of discuss her case, quickly discuss what happened with her, and then go into the actual details about intrapartum hemorrhage, etc. So Mia is Bravida 2 Para 1, which means this is her second pregnancy. She's had one delivery before. She's currently 39 plus 3 weeks pregnant, so nearly basically the end of a pregnancy. And she calls into an ambulance from home because she has severe abdominal pain and vaginal bleeding. This was a sudden onset pain. It was a constant pain, and she had ongoing heavy bleeding. And she also generally just felt unwell. She had a previous normal delivery at term. She's rhesus positive. And so far, this pregnancy has been uncomplicated. But the previous pregnancy, she did have preeclampsia. No drug history and no previous surgical history. So when Mia comes in, at least here in the UK, we got the capacity of having an ambulance to bring her in. We bring her straight to the labour ward specifically, rather than our kind of triage area, because we'd be quite worried about her and how much she's bleeding. So this is our initial assessment of her. From the end of the bed, she just looks unwell, pale, quite anxious. In terms of observations, she's slightly tachycardic, her heart rate's 112, her blood pressure is 91 and 55, so hypotensive. Respiratory rate's 24, 98% on N, her temperature's normal. We have a CTG, which is how we look at the babies. And the baby's heart rate on there is a little bit fast as well. So the baby's tachycardic, and we can also in the CTG see some uterine activity, and it looks like there's some irritability of the uterus. When you feel her abdomen, it's firm, it's generally a bit tender, all over. And when you look down below, at the moment, she's kind of got 4 large pads that she's showing you that are completely soaked in blood. And also on the ambulance, she was sat on kind of ambulance bed sheets, and those are completely soaked in blood as well. We do a spectral examination, and there's just fresh, heavy red bleeding from the cervix, and it's really hard to kind of see anything else. We start weighing the pads. I know in the previous talk we were talking a lot about how we do that for us here. So we do have the V system as well, and we do put that on when a patient gets here. But if it's anything beforehand, we just weigh the pads and then try and weigh a pad without the blood as well and see. So it is still an estimated blood loss as we've been talking about. But from our perspective, from the ambulance, we estimate that's above a litre basically, and there's still ongoing bleeding. So there's a lot of bleeding. So I just wanted to ask what people's differentials were, if they had any already, and if they had any management. I don't know if Mentimeter doesn't work, we can just do it from the chat. Is there anything? I'm trying to see if there's anything on the chat.
There should be on the chat as well, Anna. Give both a bit of time then, and hopefully you'll get some answers.
So just differentials first. Has anyone got any differentials of what's just causing major bleeding in someone who's at the end of their pregnancy but not currently in labour? Preview, that's really good. Are you able to read anything else on the chat for me?
Yeah, I can read those for you. So you've got 2 placenta previa and two placental abruptions.
Lovely. Yeah, that sounds really good. Those are definitely 2 of the major 4 ones that we're worried about. And anything with initial management?
we have in the chat more and more people saying placental abruption and for management delivery.
Good point. And I like on the Mentimeter, someone's also put ABC, so that's really good. So for this case for Mia, I will talk about everything in detail later, but just to summarize for her, so we diagnosed her as having a massive antepartum hemorrhage. We suspected with her for her to have placental abruption. In terms of management, just simple things. Again, we started with the IV access, 2 large bore cannulas. We sent off all the bloods we could think of. We have, especially here, something called the rotum. I'm not sure if I don't know if you have that elsewhere. And it just looks at how sticky the blood is at the moment. It's mainly the anaesthetists that use that for us. Obviously, fluids going in stat. We're considering giving her some blood, so getting some blood products available. Over here in our hospital, we have a call that we put out called the Major Obstetric Hemorrhage Call. And that just brings lots and lots of people. So it brings our consultant anaesthetist, our consultant obstetrician, all the obstetric doctors, the midwife who's in charge of the hospital at the moment, any porters to help run blood, the transfusion lab gets informed. So everyone's kind of aware that there's an emergency happening. And then we transferred immediately to theatre, so that was right as well. So yes, we performed an emergency cesarean section with her, delivered the baby. We did something called active third stage, which is when we talk about, so third stage is when you deliver the placenta. Active third stage, we do 3 things for. So one is we give utratonics, which is similar to the obviously we talked about in the previous presentation. We do something called controlled cord traction, where we're actually slowly, very gently, but pulling on the placenta to bring it out. So we're not letting it stay in there for a long period of time, and clamping the placenta as well. So in this case, there was evidence of placental abruption, as we suspected, because she had a retroplacental clot. There was a clot there that showed that there probably was an abruption going on for a while. In total, she had nearly a 3-litre blood loss, so it is huge. So even just an antepartum hemorrhage can cause a massive blood loss, and for her, that was 23% of her body weight. So it's a really large amount. Baby needed to go to SCBU only for a couple of days for breathing support, but then came back. So she was managed postnatally in our HDU level of care. She had 3 blood transfusions, and then she felt better. And she actually ended up going home on day 3, which was pretty impressive. So overall, the antepartum hemorrhage. So the background, so antepartum hemorrhage is classified as bleeding from the genital tract, and it's from 24 weeks of labour till before labour. So it's not during labour or after labour like the previous presentation, it's just till before labour. Globally, this is a complication in 3 to 5% of all pregnancies. So it's not always that common, but it is quite unpredictable and it can be quite severe, as with our case. And it's just associated with a lot of poor maternal and fetal outcomes. So preterm births are more likely, cesarean sections, as with this case, then going on to having a postpartum hemorrhage because they're already bleeding. And then when you get into the uterus, if there is already blood, they might have more bleeding. More likely to therefore have a hysterectomy to stop the bleeding long term, an ITU admission, sepsis with infection, thromboembolisms because they've had so much bleeding and their coagulation is all over the place, and also unfortunately death. So according to the RCOG is how we identify antepartum hemorrhage. So we have minor, major and massive. Minor is less than 50 mils of blood loss, major is 50 to 1,000 mils, and massive is over 1,000 mils of blood loss. But it's also to do with the clinical signs. So someone could have major where it's only between 50 and 1,000, but there should be no signs of clinical shock. And it's massive if it's over 1,000, or it could be less, but with signs of clinical shock for the woman. So overall causes, these are our 4, and I know some of you mentioned them. So these are the 4, kind of like we had 4 for the previous presentation, we've got 4 for this. So these are our 4 emergency causes of antepartum hemorrhage that we all have to be aware of. So placenta previa, that's when the placenta is actually covering so covering the cervix, the area that the baby has to come out to. So the placenta is in the way of that, to be unable to kind of have a normal vaginal birth because it's blocking that placenta. Risks to having a placenta previa include having previous cesareans or previous scars in the area from previous uterine surgeries. Having previous placenta previa puts you at a higher risk if you've had something like IVF treatment, or if you have multiple pregnancies as well. And smoking is a big risk factor for placenta previa. So the second one is placental abruption. So placental abruption is more when the placenta actually starts to come away from the uterus, from the inside wall of the uterus, before the baby is born. This affects up to 1% of pregnancies worldwide, so only 1 in 100. And the biggest risk factor for that is also smoking, doubles the risk for it. And we also see people who have had trauma, so maybe in something like a car accident where they've had trauma, and that causes the placenta to abrupt and tear away from the uterus. Preeclampsia makes that much more likely as well, because the placenta just isn't as healthy as it would be, and having things like high blood pressure. And the third is uterine rupture. With uterine rupture is when the muscular wall of the uterus tears during pregnancy or childbirth. So it's the actual wall of the uterus. This is kind of the little smiley C shape at the front. So the actual uterus is tearing away, not the placenta, as the previous one. And risks for this are previous cesarean, previous scars, again, previous uterine surgery, and anything that's making the placenta stretch. So some things like when we do induction of labor for women, if there's too much amniotic fluid, or if there's multiple fetuses in there. And the fourth one, which is probably the most uncommon, is called vasoprevia. And that's really, really rare, actually. It's about 1 in 2,000 to 1 in 5,000 pregnancies. So it's extremely rare to ever see it. But it's when blood vessels that travel from your baby to the placenta are covering that cervix and that os. So it's just very dangerous because those blood vessels are very weak and they can tear. And it's blood from the baby. So if those blood vessels tear, it's your baby's blood that gets lost, not maternal blood. So the baby can die very quickly because the baby has very little blood in them. And with people who have vasoprevia, 6 in 10 of those babies actually end up dying. So it's a really, really high percentage. So this is it goes into a little bit more with the 4 main ones and how their presenting features are. So like I said, with placenta previa, you tend to have painless bleeding because it's just the placenta that's bleeding, but you don't have any actually pain in your uterus. You might have a high, when they say a high presenting part, they mean that the fetus might feel quite high up still. It's not kind of lower down. You get shock because there's bleeding in the maternal shock, so hypertension, tachycardia. And the fetal condition just depends on how much blood that fetus has lost. The uterus, when you're feeling this woman, tends to be non-tender and soft, but it can be a bit irritable. Placental abruption, this is when you do tend to see bleeding. There's a few times that we talk about concealed abruption, so that's if the abruption's happening quite high up and it's not actually bleeding from the vagina, so you can't actually see it. But you tend to get constant pain when someone's got something like placental abruption. You definitely get shock again because the mother's losing blood, and there's definitely fetal compromise. With placental abruption, it's the classic kind of, we call it a woody, hard uterus. So when you're feeling the tummy, it does just feel this woody, hard and quite tender all over. With a uterine rupture, it's a sudden onset again of sharp pain. You might have peritonism in the tummy because the uterus is kind of ruptured. Again, the CTG will be very abnormal for the baby. And this time sometimes you can't even reach the baby. And as it says lower down, the fetus may be palpated ex-uterus. So if the rupture's happened, the baby might even sometimes be palpated outside of the uterus. So it's obviously really concerning. And sometimes with this, we don't even get contractions with the mum. Vasoprevia, with a really rare one, is PV loss after, usually it's after the rupture of membranes. So as you hear about with women bursting their waters, so when their kind of amniotic fluid breaks, you tend to get the bleeding after that because of those vessels. There's again acute fetal compromise with this because the baby loses its blood supply very quickly and has a really high fetal mortality. These are some of the other causes that are not the major ones, but I just thought I'd quickly talk about it. So if someone's over 37 weeks pregnant, so they're nearing the end of their pregnancy, and this is only going to be if they're having very minor APH, maybe a bit of spotting. Sometimes someone might come to you saying they have something like a bloody show. So that's just like their mucus or their discharge might have a bit of a pinky tinge to it or a bit of blood. And that just means that they're probably going into labor. Infection is always something we have to rule out, and we can always do swabs for this. Trauma, postcoital bleeding, sometimes happens in some women. It could be things like we need to rule out things like blood thinners, or if there's any like cervical pathology. Something that we see quite a lot of here is something called an ectropion. So normally, as the picture on the right shows the ectropion, so you've got the uterus, the cervix, the inside lining of the cervix has kind of this glandular tissue that's more friable, and then the outside of the cervix that you could see when you're doing a speculum has glandular tissue that's just much harder and squamous tissue. So that when someone's pregnant, we usually think it's due to kind of estrogen release, which is why it's similar with people who are on the combined oral contraceptive, have the same thing and are higher risk of having ectropions. So that, the lining from the inside comes outside. And when you look with a speculum, like the picture on the right, you can actually see the ectropion. So those are more likely to bleed as well because those tissues are more friable. And then also we have to rule out maternal coagulopathy. And sometimes with APHs, we actually never know what the cause of the APH even is. So just instead of taking the history, I'll try and go through this a bit quicker. Just want to know how much the bleeding is. How we quantify this is something that people always talk about when they come into settings. So how much are you bleeding? We like to talk about in terms of like how many pads they've been wearing or tampons they've been wearing or how many cups they could fill potentially. You definitely want to talk about the duration of it, whether it was provoked, so whether something like sexual intercourse provoked it, or any trauma like an accident. If they had any clots, what the size of the clots were, and also the color is actually quite important. If it's like fresh red blood or actually kind of brown older blood as well. Just make sure that we're definitely talking about blood being lost rather than other sorts of vaginal loss. So because pregnant women could also obviously lose just liquor, the amniotic fluid. They can also have abnormal discharge, and just being careful that we're talking about blood coming from the vagina and not kind of hematuria that they're peeing. In terms of the pain, as you would usually, the nature of the pain for us is really, significant to say, whether there's intermittent pain, that might be more laboring pain that's coming and going, or is it that constant pain like our Lady Mia had? And then the location, is it generalized or is it over the scar of the previous cesarean? So is there a worry about a rupture there? And fetal movements is always important for us as well. Obviously talk about previous pregnancies and knowing if they had any of these placental abnormalities in previous pregnancies, because that might make it more likely in this pregnancy. Did they previously have a normal delivery or a cesarean delivery? Have they previously had postpartum hemorrhage or any retained products? So that's when some products of tissue or placenta remain in the uterus. That makes them more likely for the postpartum hemorrhage or the retained products to happen again in this pregnancy. In this pregnancy, we want to know about any complications they've had, specifically preeclampsia, because preeclampsia really affects the placenta. So is the placenta not working well because they have preeclampsia? We want to know what their scans have been this pregnancy. Again, this is the luxury that we have here, that a lot of our women have lots of growth scans commonly through pregnancy. So we know how big their baby is, which way their baby's facing. We know how much fluid is around their baby. That's the liquor. The Dopplers that we do for everyone, which is how much the blood supply is from the mum to the baby, which is really important. And also where obviously the placenta is, so we can rule out things. Here we know if someone's having something like placenta previa, because at their 20-week scan, we would identify that placenta previa and keep an eye out on them. And just knowing what the delivery plan is. The rhesus status, again, is important, just to avoid any rhesus disease. So if the mum is anti-D negative and the baby's positive, we need to be aware of that. So coagulopathies for a past medical history, normal routine past medical history questions you would take. Surgical history for us, specifically looking at the uterine surgery, if they've ever had anything like that before. Blood thinners, of course. Smoking, as we know, is a bigger risk. Routine examination, obviously everything that you guys would usually do, seeing what the heart rate's doing, the blood pressure, etc. We always do a CTG as a baseline when a baby comes in, and we see how the baby's doing. Is there any signs of fetal distress with the baby? And also what the uterus is doing on the CTG. Is she contracting or is there just irritability? Like we said previously, so with examination, the abdomen is tenderness. Is it generalized or is it just on the scar? Does the tummy feel soft or does it feel tense? Are there contractions? Is there that woody appearance we're talking about? And the presenting part, which is like the actual baby. So how far down is the baby? Is it actually quite high up or is the baby lower down as if it's engaged and about to be delivered? From a speculum point of view, we want to obviously see, is there any active bleeding at the moment? Is it light, moderate, heavy? Are there clots? Where is the location of the bleeding? Where is it coming from? Is it coming from that ectropion we talked about, or is it actually coming from inside the womb? And it's just a point there to consider any kind of like STDs and STI swabs if there's any minimal bleeding and we're thinking this is more infection than bleeding. Not going to happen in the 4 major cases, but just something to think about if it's a minor APH. And just something we always talk about is just do not do a vaginal examination unless they've had scans and you've ruled out that there's no kind of placenta in the way that you could accidentally poke and cause a worse bleed. In terms of management, this is just our protocol that we have here, and we just have this laminated in all our beds and in our hospital. The first thing is just calling for help. So that we always say is our first line management. If anyone's coming in bleeding, is call for help before starting all the other things, because there's a lot that needs to go into this, and you need to have a lot of hands, like that octopus in that first presentation. You need to have a lot of hands to try and help. So we want to obviously declare if this is a major APH, if there's a maternal collapse, or we need to declare it when we're calling for help, and so we identify who we're calling for help. So on the actual diagram on the right, in terms of the actions, so we often do a thing where we lie the woman in the left lateral position. You might have heard of this generally when we talk about pregnant women who are unwell, and that's just trying to release pressure from the inferior vena cava because the baby's sitting on that. Give high flow oxygen if that's needed. We talked about the cannulas or the bloods that you have to take. Group and save is really important, obviously, in getting the correct blood type for the mum, if we can get the correct blood type, and if not, we just go with our standard kind of O negative, fluid replacement, and checking what's happening with the baby. We talked about a lot about the assessment bit already in terms of observations and the history and the examination, but it's just really important to say we're just constantly weighing the blood loss and trying to see how much is still ongoing. In terms of stopping the bleeding, we have to think about the birth. Does it need to be expedited? As people said in the chat before correctly, just do a cesarean. If someone's bleeding that much and we're worried about the baby and the mum's in shock, a cesarean is the best bet in that situation. And just think about whether we need to call someone like the neonatal team because the baby's preterm, for example, potentially. And then when it comes to the actual cesarean or the birth, then it kind of moves on to the postpartum hemorrhage things that we've talked about in the previous presentation. So I'm not going to go into all the uterotonics again, but it's very similar to what we talked about in the last presentation. The main thing with antepartum hemorrhage is just getting the baby out, really, if it's a major antepartum hemorrhage. If it's a minor or moderate one, we can kind of step down all those things in terms of delivering the baby. Again, the assessment is very much the same on the diagram on the right. The actions, again, are very much the same of what we would do. But in terms of our plan, our guidance here says if anyone has a minor or moderate antepartum hemorrhage, but we're not worried about the baby, there's no fetal concerns, the mum is stable and well, and she's pain-free specifically, we just keep them for 24 hours. So we admit them for 24 hours under our bay, and we just watch them and watch for any bleeding. And if they're fine after 24 hours, then we consider sending them home. It says there on the right side as well, is delivery anticipated? And this is because if someone's preterm and we think they will need to deliver soon, over here we also offer women steroids and magnesium sulfate, which is a way just to help develop the maturity of the baby's lungs. I thought I'd just talk a little bit from a global health perspective about antepartum hemorrhage if I can. So I'm coming to the very end of it. I actually really struggle to find antepartum hemorrhage specifically statistics from a global health perspective. Most of it talks about postpartum hemorrhage or in general obstetric hemorrhage. So obstetric hemorrhage in general, which is both antepartum and postpartum hemorrhage, is still one of the major causes of maternal death worldwide. And it's estimated that's 50% of the 500,000 maternal deaths that occur globally each year. So that's obviously a huge number, but a lot of that will be postpartum hemorrhage more than antepartum hemorrhage. I was trying to just look a little bit about Kenya and the UK just to see what was going on. I did struggle a little bit to find the most up-to-date information. So just to kind of be aware, obviously the birth rate is going to be very different for these countries. So we can't just compare numbers for number because the birth rate's really different. But in Kenya, for example, the birth rate in 2024 was 27.071, whereas in the UK it was 11.17. So there's a big difference there. Obviously, we're delivering a lot more babies in Kenya. And then in terms of the actual, I was trying to see how many of those babies might have had something like an antepartum hemorrhage, and I did struggle to find it. The best thing I could find from the Kenya point of view was actually a report. It was unfortunately from 2015, so it's quite a long time ago. If anyone has any up-to-date resources, that would be amazing. But on there, it kind of shows you that hemorrhage was 44% of women who had hemorrhage. So that's a direct cause of a maternal death in Kenya, whereas ruptured uterus was the only one they talked about, which was 3%. For us in the UK, on the other side, we have something called the Embrace report that gets released every year that just looks at maternal and neonatal well-being. And on the right there, it's at the very bottom, basically, it says obstetric, lower down it says obstetric bleeding, 7%. And it was 18 women last year that died of obstetric bleeding. So again, that was a mix of APH and PPH. So I'm not entirely sure if it was just APH. And then my last slide, I promise, which is just, and again, we talked about it in the previous presentation, and I really, whenever I think about global health, I like to think about it in kind of 3 stages when you look at, just the whole world and accessing medical care. So the first thing that a patient needs to do is they need to recognize that there is a need for them to access care. And that's, in any country of the world, even here. And obviously, number 2 is they have to actually reach the facilities. And then number 3 is they then have to receive that care. And I always like to break it down into these 3 things when I think about it globally, because I think it really helps. And then we can think about the differences that happen in various countries. So in terms of recognizing the need for care, obviously antenatal education is going to be very different in different countries, and potentially things like the availability of scans, because if someone has a scan antenatally, they're going to be aware if they have something like placenta previa that they need to be, monitor their bleeding. So number 2 is reaching facilities. Like we said in the previous presentation, I know it's a bit repetitive, but it is location of where we can get the facilities, how far away they are, and then financial constraints of going to those facilities as well. Sometimes even just if you have antenatal appointments, over here we always have a luxury that we offer a woman lots of antenatal appointments, sometimes too many. And you've got to think in rural parts of the world, how are people getting to these antenatal appointments? Whether that's just for to see a doctor or a midwife or to get a scan. And again, the financial burden of multiple appointments. And then while they're actually unwell and bleeding, how are they reaching these facilities whilst they're unwell? I've seen some programs where high-risk women are moved to a location closer to a medical facility during their last few weeks of pregnancies. But then there's also a burden on the family because a member of the family is kind of going away and moved to a different location. The other thing I was just thinking is also the difficulties just quantifying the blood loss. If someone's traveling, for hours to reach a place, it's going to be really hard to quantify and actually be aware of how much blood this patient has lost. And the last thing, obviously, with receiving care. So resources is probably the biggest thing with this. Antenatally, I was trying to see why our statistics of APH have reduced. And a lot of studies have said that they think that's because of aspirin antenatally here that we give to a lot of our women. We see whether they are at risk of having preeclampsia antenatally. And if we score them as being risky, we give them aspirin, and that reduces the risk of APHs in the future. Preeclampsia mainly, but which also is associated with APH. And then resources when they actually get to the hospital in the emergency. Have they got skilled staff? Are the theatres there? Is there blood supply? The equipment and medication to help stop bleeding? And I know we talked about this before, but there's so many things, and I'm sure there's more than what I've written on here, and plenty more. Yeah, that is it. There was a quiz. I don't know if we've got time for a quiz, if people wanted a quiz.
Thanks, Anna. I think leave the quiz up. We can have those questions sort of float in the background, and if anyone wants to pluck those out and ask questions to you, then that'd be great. So I think you need to just share that screen back across. Great. That was great. Thank you very much for sharing your time and presenting there for us about antepartum hemorrhage. I've got a couple of questions myself, but I just want to open up to the floor. If there's any questions that you have, please unmute or put them in the chat. And then equally, Dr. Anna and Dr. Karen, if you want to ask each other about each other's topics, postpartum hemorrhage and antepartum hemorrhage, that'd be insightful as well if you have any questions for each other. But I'll open up the floor first to anyone who's got any questions. That's the magic 10 seconds. We haven't got anyone unmuting or putting anything in the chat specifically. Anna,
Maybe I can mention
yes,
there's someone
please.
who had asked a question on my personal, she said, or he or she sent it directly to me. Maybe I can help with that. Okay, so and previously I can see someone else who had asked about how do we assess when hemorrhage is due to coagulation disorder. That's a very good question. I think most people don't really think about coagulation disorder first. Well, it can still be one of the reasons. As I said, there are people who even have disorders that were never known or were never diagnosed. But then when they keep giving birth, they keep having postpartum hemorrhage and it keeps repeating itself. So one of the ways to know is first of all from the history. When you ask them, when you're taking the antenatal history, previous pregnancies, if they've ever had a postpartum hemorrhage before, most likely think at the back of your mind that they could be having another reason other than just etoning. And blood disorders are the issues. So one of the other things is to check whether they have bleeding from the puncture sites. If they had a cesarean section wound, you can also see they're still bleeding. Maybe the scar, the dressing is wet or it's soaked. That can be one of the signs of a coagulation disorder. And if you suspect that, also you can actually do a bedside bleeding time, or you can do a coagulation screen and check whether they have an issue. Some of them will also present with history of nose bleeding, just recurrent nose bleeding. You need to be very careful about that, because other than just the usual reasons why people nose bleed because of that sensitive blood vessels, it's possible that they could be having a coagulation disorder. Yeah, I think that's for that. And then there was another one. I can't see that. Yeah, okay, if I find it, I'll mention it. I'm just looking for it because I replied directly to her.
No problem. I've got a question. So I suppose what we're doing today is sharing and learning from each other. And a big part of what you've both touched on is sharing the these sort of presentations and the knowledge around antepartum hemorrhage and postpartum hemorrhage with colleagues, and sort of that notion of task shifting. I mean, that is an area that is exciting and extremely relevant to sort of share the burden of this sort of disease process, if you want to call it that. I think my question is around what the challenges are with the buy-in for these individuals, both here in the UK and in Kenya, around sort of this process and what the solutions may be. You mentioned Dr. Karen around using community health volunteers, antenatal screening, and traditional birth attendances and attendees. Sorry, I just wondered, did you find it easy? Was there any barriers to what you were trying to achieve and how you got around them? I know you touched on a few of them in the presentation, so apologies if there's a bit of repeating.
No worries. I think it's still something that is ongoing, because traditional birth attendants have been there for years, and they have been delivering patients, particularly those ones with socioeconomic issues, particularly cultural. So you find particular traditional cultures in Kenya, what we call the pastoralists, the Maasai, the Samburus, they live in the outskirts, like in the insides of, what should I say, rural areas, very, very rural areas that are very far from any dispensaries. Because some dispensaries are able to deliver. They actually deliver, but they're not comprehensive centers. They're only able to deliver and hope to God that the patient remains stable. So when you find a birth attendant, the initial uptake of conventional medicine in terms of teaching them at first, surprisingly, they're open to being trained. Yeah. The only thing is that they still take time to recognize when there's an issue, because they know that they can still do it. So you'll find a patient who's been in labor for more than a day, and they're in active labor, and yet they've not made the decision or the recognition that there's an issue. There's one patient I did have a long time, that was 6 years ago when I was still here in Nanyuki. I left and then came back. And she was, again, a patient who had had a previous cesarean section because of CPD. She was young, again, from the same community. And she was supposed to, so she knew that she was coming back. She was supposed to come back for a second cesarean section when she gets the next baby. But now, because of that cultural thoughts and beliefs that the reason why you went, they don't want her to go to the hospital because when you go to the hospital, you're going to have a cesarean section, and they don't want a cesarean section. So they believe the first time was not supposed to happen. She was supposed to just deliver vaginally. So they stayed at home with a birth attendant. They tried again and again. They got CPD. She came in with obstructed labor. They had tried to even cut the perineum. So she was damaged, like literally mutilated again, other than the FGM that she already had. So it's they know. The only thing is that sometimes they take longer to make a decision, and that's the area that we need to make very clear, because sometimes we're not able to say every woman should come to the hospital. No, not everybody will make that. You've seen the delays that Anna has talked about, the decision making to go to the hospital. Like now, you have a cesarean section and you don't go to the hospital. That recognition is sometimes the main issue. Then the TBA will still try and help her conceive at home, rather than tell her, no, this one should go to the hospital. So there's still a bit of delays, even if they know. Sometimes they still follow, because they are also from the same community. They still remain with the same beliefs until it's a bit too late. So I think awareness is something that we need to still do. Go out there, empower the dispensaries as well, so that even when they see a patient, they follow up, like the CHVs, they should be able to follow up such patients who are at risk, PPH, previous scars, young teenage mothers. Those are the ones that we really need to empower the CHVs and the trained traditional birth attendants to keep, recognizing where there's a problem.
Can I ask as well, do you
Yeah.
with your emotive, obviously, system,
Yeah.
is there a way, or is it like a grab and go bag, like a bag that has all the things you're saying in it, the V and the uterotonics, and it could just be like a bag that has all of it that can just be put into different communities? I don't know how possible, or if that's a thing already.
It's very possible. It's very possible. It's not the thing already, because only maybe the comprehensive care units have them, but the smaller ones may not have. But it's possible to do a PPH kit, particularly for emotive, because now at this point we can be able to, if we have enough resources, like if we do have the VDRIPs, because the VDRIPs is the only thing, and also the medication, the drugs, yeah? Some of them need to be in a fridge. They may not be in a package. Yeah, like now the oxytocin, unless you're doing carbetocin, you can actually put it in a kit, heat stable carbetocin. But the VDRIPs also, if we have them, then we can be able to put in a kit. But PPH kits are there. They may not have all the things, including all the drugs, particularly oxytocin, but just the normal PPH kit there is. We are yet to put the VDRIPs on there, or supply VDRIPs to other facilities. But that's a very good idea. I think it's possible to do carbetocin and put everything in one place. In case that there's PPH, they'll still have to use oxytocin. Yeah. Thank you for that question.
I can see on the chat that someone said, how does aspirin prevent future occurrence of APH? Sorry, I probably just didn't explain that very well. It's more that aspirin, we know, prevents preeclampsia, which is a risk of having APH. So it's more actually related to preeclampsia specifically, rather than a direct thing that will help APH.
That's brilliant. Thank you very, very much, Dr. Karen, Dr. Anna, for spending and sharing your time with us today. I can safely say you've scored the highest amount of participants on our grand round to date. We've reached 3 figures. So thank you for those extremely brilliant presentations. I'm going to hand you over to Charlene, who's going to round things up and cross the T's and dot the I's. But I just want to personally say thank you very much for your presentations today.
Thank you for having us.
Thank you.
Right. I've posted the feedback form in the chat. If everyone could fill that out, that would be amazing. And you'll get the certificate of attendance once you filled out the feedback form. And then we could distribute the feedback to you, Karen, and you, Anna, if you guys are interested. Our next grand round will be on the 9th of April. So save the date for that one. And yeah, keeping updated on the WhatsApp group. Again, thank you, Anna, and thank you, Karen. I feel like even though we were very far apart, it felt like we were all in the same room speaking about women's health and a very nicely matched topic. So I really enjoyed that and the interaction and obviously the high number of participants. So congratulations.
Thank you.
Thank you very much.
The feedback form is still in the chat.